Hello and welcome. My name is Dr. Anna Smith, and today I'm going to do a talk on chronic pain and medically unexplained symptoms. What can a busy GP do? So let me briefly introduce myself first. I've been an NHS GP for 28 years. I trained in medical acupuncture 7 years ago with the British Medical Acupuncture Society in London and gained my certificate and diploma in acupuncture. I completed my lifestyle health diploma with the British Society of Lifestyle Medicine, and I trained with SERPA in mind-body medicine. I run a private clinic called Health and Wellness GP in West Oxfordshire. So let me go through the topics we're going to cover today. So we're going to look at acute versus chronic pain because they're very different entities. We're going to talk about central sensitization and neural pathways, which is the basis of chronic pain. We're going to talk about medically unexplained symptoms. What are they? We'll look at analgesia and scan results, how a mind-body practitioner manages patients with chronic pain and medically unexplained symptoms, and how can we manage these patients in general practice. And we'll also look at some resources as well. We'll just start off with some case studies. I thought I'd do this, and at the top I put, what do these case studies have in common? Well, they are very typical patients that we may see within our general practice clinics. So the first lady is a 64-year-old female, keen walker. She had 9 months of fatigue and years of generalized pain. No red flags, her blood tests were normal. She had quite a lot of stress with being a carer for her elderly father. She had an adverse child event, and she also suffered depression and anxiety. The GP thought she had fibromyalgia and decided to refer her to the rheumatology clinic, but the patient asked her, while I'm waiting for my clinic appointment, how can I manage my fatigue and pain? And the GP said, well, you just have to take each day as it comes and see how you manage. Then we have a 29-year-old accountant who had a COVID infection, followed by 5 months of fatigue, pain, and memory issues. No red flags. Again, the bloods were normal. He had a lot of anxiety. He is a perfectionist, which we'll talk about why that's important later on. He has a lot of stress at work, and his wife is pregnant. His GP decided to refer him to the long COVID clinic. And he asked his GP, while I'm waiting to be seen at the long COVID clinic, what can I do to help my fatigue? And the GP said, well, you'll just have to rest, until then, and take it day by day. And the last patient is a 70-year-old retired IT consultant who is a keen gardener and walker. And one day in his garden, he kind of lifted a pot, twisted round, and had acute back pain. So he went to see a physiotherapist who gave him physio exercises. The back pain didn't get any better, so he was referred on to a spinal surgeon who did an MRI scan, which was unremarkable. And the surgeon said he would not consider surgery, and so referred him to the pain clinic, where they offered him medication, which he wasn't overly keen on. So I saw him after a year of having gone through that process, and he was quite depressed because he wasn't gardening or walking anymore, because he was convinced he had structural damage, and any gardening or walking would make that worse. So what we'll do is we'll come back to these case studies at the end of the talk, and perhaps you'll hopefully have some resources that you could give these patients. So let's talk about acute pain first. Okay, acute pain is a natural response to a tissue injury with a recovery time, usually 6 to 8 weeks. And what we call nociception is a large part of the acute pain response. So let's pretend I'm walking along, I fall over, I fracture my ankle. What will happen is there'll be lots of inflammatory chemicals released. They will stimulate the nociceptor receptors in that area, which will send a nociceptor stimulation to the spinal cord and brain. The brain will interpret those messages in various areas of the brain, and it will think that my ankle needs protecting because I've injured it, and it will send out, therefore, a message of protection, which is pain. This is great because then I'll seek help, I start walking on it, I rest my ankle, and I have a good recovery within 6 to 8 weeks. But let's look at chronic pain now. Chronic pain also is pain that's created in the brain, but there's no structural injury, and it's a biopsychosocial problem. So chronic pain is something we've had for at least 3 months. It may be neuropathic, which is, for instance, a patient with diabetes who has diabetic neuropathy, or it may be nociplastic. And nociplastic pain is what we're talking about today. And that is caused by an immune response in the central nervous system and an autonomic nervous system response in the central nervous system. There is almost no nociception. It's all based around central sensitization and learnt neural pathways. So let's go on to discuss that a bit further. So on this slide, we have, let's start at the bottom left-hand corner. What happens is a patient has an emotional or a physical trigger, which sends a message to the spinal cord and up to the brain. The brain has these microglial cells in it, which are like the housekeeping cells, but they have become inflamed. They activate astrocyte cells, and you have a very oversensitive central nervous system. So that brain becomes almost like a car alarm. It's like a car alarm that keeps going off every time someone just walks past. So what happens is it sends out a message of protection, and the message is pain. This all happens unconsciously and automatically. It's called central sensitization. Fear and anxiety are fuel to the fire and create this learnt neural pathway, which is very easily triggered. We also get activation of the autonomic nervous system and the hypothalamic pituitary adrenal axis. So there's lots of cortisol and adrenaline released, and that causes dysfunction in various systems in the body, such as bowel, bladder, sleep, energy levels causing fatigue, mental health issues causing depression, anxiety. So that explains why someone with fibromyalgia may suffer pain, but they may also have symptoms of irritable bowel syndrome and fatigue. So why do some people have an oversensitive central nervous system? Well, because of either childhood stress or trauma, adverse child events, chronic stress in their life, and personality types, because personality can create an internal stress. Mental health issues such as anxiety and depression, and lifestyle factors such as how we eat, how we sleep, how we move, how we relax, all have an influence on that oversensitive brain and central nervous system. Let's just go on to look at some of what we call the medically unexplained symptoms which are triggered by this pathway. So medically unexplained symptoms are a symptom with no organic or structural problems. They've been investigated and they have no organic issue. It's a biopsychosocial model. It's very common, up to 30% of people in primary care and more in secondary care. And I'm not going to read through this list, but I'm sure you'll recognize some of the conditions such as fibromyalgia, chronic pelvic pain, vulvodynia, irritable bowel syndrome, chronic fatigue. So let's now talk about childhood adverse child events, explaining why we get an oversensitive nervous system. So adverse child events, trauma. This could be caused by death of a parent, mental illness in a caregiver, addiction, violence, divorce, physical or sexual abuse. It causes a huge inequality in health. It's actually very common. 64% of people have one ACE and 12% of people have 4 ACEs. And if you have an adverse child event, you are significantly increased risk of chronic pain, fibromyalgia, and medically unexplained symptoms. You also have risks of other diseases such as autoimmune diseases, cancer, ischemic heart disease, stroke, COPD, obesity, and mental health, to name a few. So why do adverse child events cause disease? Well, there's various reasons, such as epigenetic shifts, a change in the gene expression, a change in the brain's size and shape as it develops in childhood. Those microglial cells in the brain, which we talked about, become overreacted and inflamed. Telomeres, which are at the end of our DNA strands, which usually are quite long in childhood, but then as we get older, get shorter, are shorter in people with adverse child events. The default mode network, which is a network in the brain that can work together, does not work in the usual way. You've got different brain connectivity in people with adverse child events, and you have emotional suppression and dysregulation. And that all causes things like central sensitization, leading to chronic pain, an overactive immune system, which may lead to cancer, an endocrine imbalance, such as metabolic syndrome, and neuroinflammation, causing mental health issues. So let's now look at some of the other factors that affect the central sensitization, such as chronic stress, personality, and lifestyle. So chronic stress is not good for the body. It causes a lot of inflammation in the body. So we all recognize the causes, such as work pressures, social media, emails, relationships, finance, health, etc. But personality can also cause a kind of chronic internal stress as well. And what we notice is people with chronic pain and medically unexplained symptoms tend to have a personality type, which often is a perfectionist. They're often self-critical. They're very driven. They're people pleasers. They're anxious, reliable, non-confrontational, like to be in control, to name a few. Lifestyle is hugely important. How we sleep, how we eat, how we move, and how we relax and connect with other people affects our health. Sleep allows rest and repair of cells. How we eat, for instance, if we eat a healthy, whole food, plant-based diet, we're feeding our microbiome. If we feed our microbiome well, it sends messages to our brain, which calms that oversensitive nervous system. So this is almost another talk, really talk about lifestyle. So I've just mentioned it here because it is incredibly important. Medical interventions. What we need to realize as doctors is the level of pain does not equal the level of injury or structural damage in chronic pain. We need to look at analgesia and consider the type of pain we're treating. Are we treating nociception, that acute pain, which will respond well to pain relief, or are we treating nociplastic pain, which does not respond well to analgesia? And a useful website for this is thenumberneededtotreat.com. And we also need to look at scan results. They do not equate to the level of injury or pain. So let's look at analgesia first. So let's start with nociceptive pain in the bottom left-hand corner, the acute tissue injury. Drugs are very effective in this. What we talk about is number needed to treat. So anything under 4 is beneficial. And what that means is to treat one person to get 50% pain relief. So something like paracetamol, maybe about 3.5, and something like ibuprofen, maybe 2.5. So they're effective medications in an acute tissue injury. If we look at neuropathic pain where there's nerve damage, drugs can be effective. Something like amitriptyline can have a number needed to treat of 4.9. Gabapentin would be about 7.8. But when we look at nociplastic pain, the chronic pain, drugs are not effective. There is no tablet cure. And let's just go on to talk about the long-term effects of opioids. Opioids actually cause suppression of endogenous opioids and down-regulate opioid receptors. And so what they do is they lower the pain threshold. So in fact, people need more pain relief. So that increases the risk of physical dependence, abuse, and addiction. Opioid analgesia also induces central sensitization, which promotes persistent pain and hyperalgesia, a sort of paradoxical state of increased pain sensitivity. And then we have long-term use of opioids, which have side effects such as increased falls and fracture risk. And when we look at scans, we need to consider that they may be wrinkles on the inside, as these are the normal scan results of people age 50 with no pain. So you can have a little look at that. 72% had a labral tear in their shoulder, but they had no pain. 80% had disc degeneration in lumbar spine, but had no pain. 58% had a labral tear in their hip, but had no pain. We need to consider the whole person before surgery. So what does a mind-body practitioner do for people with chronic pain and medically unexplained symptoms? Well, we use pain reprocessing therapy for a biopsychosocial problem. We talk about education. So what we do is we explain central sensitization and neural pathways. So what I say to patients is, look, you have like an oversensitive car alarm going off in your brain. It's going off every time someone just walks past your car. And then what happens is fear and anxiety are the fuel to the fire. So that drives that neural pathway. So with education, the number needed to treat is 3. So it's excellent. It's under 4. We talk about lifestyle. We talk about how people eat, because that has a huge effect on chronic pain, how they sleep, how they relax, how they move. We look at emotional factors such as stress awareness and emotional awareness. And we look at behavioral factors such as feelings, thoughts, and behaviors. But most importantly, what can a busy GP do? Well, obviously, as a GP, you really need to rule out a structural organic cause. That is number 1. Once you have ruled out a structural organic disease, you may consider a mind-body disorder. Is it functional? Are the symptoms not explainable by a structural cause? Is it inconsistent? The symptoms vary in a way structural symptoms wouldn't. Is it triggered? Symptoms are brought on by a stimuli, which you would expect would physically cause the symptom. You need to carefully communicate the scan results to reduce anxiety. Remember wrinkles on the inside. And maybe then introduce your patient to the concept of a mind-body disorder. I say to patients, maybe that you have a condition called a mind-body disorder, and then I'll give them resources, which will be on the next slide. You may refer them for social prescribing to secondary care or the pain clinic. You may consider acupuncture, physical activity. You may review their mental health and give them lifestyle advice. And you signpost them to resources as well, which I'll show you on the next slide. But give them hope. These people can make a good recovery journey. So these are resources that I talk to patients about. So we have various websites such as serpa.org, which is run by Georgie Oldfield, and there's lots of free resources on there. There's practitioner training, and there's courses for patients with chronic pain and medically unexplained symptoms. There's also unlearnyourpain.com, run by Howard Schubiner, which again has a lot of free resources. You might like to listen to the podcast, Feel Better, Live More, episode 310, where Dr. Howard Schubiner was interviewed about chronic pain. And then we have apps like Curable. If you sign up for Curable as a practitioner, which is free, you can then give your patients 6 weeks free Curable, which is a useful resource for them. Or we have Nerva, which is for irritable bowel syndrome. And then books I recommend are Chronic Pain by Georgie Oldfield, The Pain-Free Mindset by Dr. Deepak Ravindran, the pain consultant at Reading Hospital, The Way Out by Alan Gordon. And for lifestyle advice, I tend to, again, we're short of time in general practice, and I tend to recommend the 4-Pillar Plan by Dr. Rangan Chatterjee. So let's go back to those case studies. What can the GP say? So remember our first case, the 64-year-old female, Keen Walker, who had 9 months of fatigue and years of generalized pain. So one, the explanation. You have an oversensitive alarm system going off in your brain. It's like the car alarm that keeps going off every time someone just walks past. We may refer her if we wanted to. We may look at resources with her, books, apps, websites. We would review her mental health and stress as we would in GP surgery. And we'd encourage activities. We might encourage boundaries about caring for her elderly father, and maybe suggest she try some journaling for emotional expression. And then for our 29-year-old accountant with 5 months of fatigue, pain, and memory issues, we may again give him an explanation about what's going on. We would refer him to the long COVID clinic. We might give him books to read, podcasts, review his anxiety, and maybe suggest things like yoga and journaling to calm his nervous system. And then remember the 70-year-old IT consultant with back pain. Again, we'd give him the explanation. We'd look at resources which would suit him. We would reassure him there was no structural injury, and would encourage him back to his activities of gardening and walking, which would help his mental health, as well as we would review his mental health. So thank you very much for listening to my talk. That's the conclusion of the talk now. If you have any questions, please feel free to contact me at Health and Wellness GP, and my email is anna@oxengp.co.uk. Thank you for listening.